two other real things that can happen from a visit perspective is they can go back to the clinic and they can go to the district hospital for high acuity or for delivery. And so let's spend some time walking through that real quick. So a mom, once she's known to be pregnant, she then goes back into a clinic. Same registration process that we talked about before. She then
she'll already be registered. I'll show her the first time she registered, but they'll just find her visit again. She doesn't need that formal registration.
Right. And so she comes in for routine care as part of antenatal care. I think one other series of questions relates to what does the clinician need to be aware of that's happened independent of the visits that have happened just in the clinic. Okay. So one example is the high risk conditions that have been identified by the RAC, that's the Master of Community Healthcare Worker. So that's a you don't think there's high data quality of those or something? Or?
Yeah, normally the risks, that is one thing. If she had an episode of bleeding or something like that, but sure it's not fair because they did an assessment of the data that the community health workers were producing and had a high tendency to under-report. Which is not the same message.
Right. You're saying they just don't use it as often for the reporting.
It's more likely things like fever and that sort of thing than it is. I don't even know how they would identify that someone has a clear plan and say they can't take blood pressure.
Do they do things like, like super overt edema in the legs or things like that?
They can do edema.
Okay.
But even in the training material, I would be concerned about at least initially in the first sort of year or so, their ability with clinical observations that are significant of them. And I think that might be what I am to report.
So, I think we can accept the fact that that's a work in progress, but we can also accept the fact that as that matures, those will become increasingly valuable.
Yeah.
And so, right now, those are recorded as separate encounters, and is there a place inside the summary for those to pop up?
No.
Okay.
We should have.
Do we want that?
We just need to notify. We need some notes to make sure we know from community health.
Okay. So could we go back, Wayne, to the summary, please? Go ahead.
I was just going to say, as I understand it, the message will include all the encounters that have happened, including those at the report about community health.
I think the data is there. There's no question. Any question whether they're rendering it in any way.
Okay, so actually, then there would be underneath that bottom one encounters. We just hadn't discussed that.
Okay. So is that the bottom of the encounters?
It's not in the same format, so we'd have to do something different.
That's the bottom. That's not. So there's not an encounter list during the pregnancy on the summary sheet. I guess the question is, if they have some kind of birth date identified, where do you want it to go on the summary sheet? And it's probably we don't need to do all that work now, but I think what we're saying is we probably need to find some way of reflecting what happens outside of this visit on the summary sheet. Okay, so that's a to-do.
All they don't do it right now, there is space for tests, interventions, medications, etc. So if they were to go on a drug or something else, we could theoretically go there just so they don't put the insured right now with the nurse.
And what about the PMTCT case where there's someone that
It's all in
where is that?
the seropositive for them.
Sorry. Okay. So they'll have a specific list there, and they'll have medications that they're on. Okay. But
You have to have like these 4 counts in the standard.
okay. Is there anything else that the clinician would want to be, we need to alert the clinician about besides what happened between visits?
From a community health worker as well as from another visit in the clinic.
Yeah.
Although that's been a problem.
I mean, I wonder whether a rudimentary way would be able to show an encounter list, and then encounter list could be all of those three settings, and they could, if they want to dive into looking at the details of those encounters, they could do that.
So the encounter list would be only from OpenMRS, not from SharePoint.
No, it would be both, which includes the hospital, the
Yes, I think based on our earlier discussion on that issue.
Are you suggesting just lists of 3 types of encounters, or are you just suggesting sort of a list? Here are the previous encounters. You can click on them.
well, that already exists in OpenMRS, so you show the encounter tab and you'll see all the previous encounters.
So which are what are you suggesting?
I'm suggesting the thing that's already there.
Okay.
Certainly the local copy would be there, but I think that it's going to be difficult for us to capture what happens in between visits. Actually,
Well,
if that same one comes in,
they're encounters.
we have a problem with if that same person comes in and is now registered in acute care, if they don't register her in acute care with their ID, you can't find her anyway.
So when they register in the clinic for, okay, so that's the thing I want to talk about. So there are a whole host of visits that are not ANC visits that are typically of higher acuity. They're seen in the primary care setting. There is no pathway towards the end information trickling up to the shared health record, correct?
Yeah, that was my little rant before lunch.
Yeah.
About that, how we find our pregnant women in those piles of patients. And first I was worried that we were going to take them all, but we're not, because we have separate registration module for antenatal visits. It follows the same pattern as the other one, but it's not that same.
Are there any just sort of ad hoc rules you can build here to launch through the system to say, it's female and she's a childbirth age, oh, by the way, she's got something that's a proxy for pregnancy? So the heuristic. Yeah, the heuristic.
So to my understanding right now, in the acute care visits, they are not entering reason for the visitor diagnosis.
Yeah, so don't even think about that. Is there some sort of test, some sort of observation, some sort of thing they do in OpenMRS?
I think the more fundamental point you're bringing up is that there's no information in the system to send. That they're seeing them, they're identifying by acuity, but there's no data reflected in the system for it.
So they're registered for the visit in OpenMRS, but that's it. That's the end of your account.
Yeah, they're not doing,
There's no information in that visit.
right, except for vital signs if they have it, it's taken on registration. If there is a plan underfoot to do some coding on that, but as far as I know, it's not done yet, is it? If they're entering the reason for visit? And in an acute care visit, in MRS, they enter the diagnosis afterwards. Right, yeah, but they're working on that, but it won't be ready for us.
So that's not in the next 6 to 9 months.
No, it's available. I think
But they're not doing it, that's they've been trained, there's.
there's someone finishing it, so you can go.
Could they be in the next? But I think the other.
Maybe in Rome at the hospital.
The next week. So we've been waiting for the mapping, so next we'll get enough time to see
Right.
affecting the actual
Yeah, there was training that had to accompany that, to make sure that they use the right codes and that sort of thing, right? What do they, what would they equivalent to, et cetera, et cetera. So it's not done yet, but it will be done maybe by tomorrow.
Okay. So for round 2, augmenting additionally with the higher acuity visits, unscheduled visits from the clinical setting, maybe we get an HL7 message of those that are shared health record as well. And in that case, we don't cherry pick the ones that are internally related. We just get all diagnoses sending up to the shared health record
Yeah.
from those settings.
Yeah, and the problem that we're going to have with that is currently the registration that they do. Not every single acute care person comes with their NID. That's a change process in Rwanda to bring their NID card to get treatment. And most people don't have their NID memorized. And so if we are now going to use that as our identifier in the OpenMRS system, we won't have a good way to match to all the acute care visits on those registrations.
I thought we said in the previous workflow that they could either bring their card or they could type their demographics in and we would try to find them through a query to the shared health record.
Yeah, but if the acute care visits, they came through in many an hour. And it's going to be, we're going to have tons of matches. And it's going to be trying, yes, theoretically do that. But it would be greatly concerned that they would fix as many matches as they think.
Okay.
But just because of connectivity, speed, how many registrations they have at a time.
Okay. So that's 2.0.
Yeah, and they do use their mutual number right now, but we have no records database that has a connection between the entity and the mutual.
He does. Richard does. I asked him about it at the break. There is a linkage between Richard. There is a linkage between mutual and NID numbers.
In which,
But we don't have it in electronic format.
yeah.
It's in paper records. in
Oh, it's
each
only
entity.
paper records. Oh.
Yeah,
But
but
we will eventually have it in the membership database.
yes, that's what we have the new membership definitely. And that's the one we're going to use to issue new cards right now.
That's right.
Yeah, so
But it's not, it won't be active till July.
Sorry?
It won't be active until July.
And it'll be populated by
Andrew's decision. It won't be populated.
Yeah, it won't be populated probably until July. The database is there, the web, but we're waiting for a cell phone interface so that because so many of the mutual sections don't yet have computer access or haven't been trained in using the web interface, etc.
Okay. For this implementation, yeah. Okay, so for now, we're just going to stick to the area I can't control again. Okay. But just as a recognition, that's a huge lost opportunity, right? Just for the improved care. Because a lot of the high acuity is you're most concerned with.
Yeah, and just to point out too, here, often if you have an obstetrical complication, but it's in between your antenatal visit times, you go to the regular clinic. And so even obstetrical complications, we are going
Go to primary care.
go to the primary care setting.
Lamenting that we're not going to be able to find that record because we don't have necessarily an MID.
No, it's more complicated than that. It's also because they're not actually documenting the visit to where the information is even have anything useful clinically.
Roberta said that they hope to be. So if they do that in the summer and you can match to each trial, I think we can do it.
But I think what we're saying is,
The time is 10.
yeah, more than tight. Okay, but that's where we need to go eventually, I think. Okay, anything else with the clinic in terms of repeat visits? I think we pretty much beat it. So then the last one is the hospital. And the hospital is going to support high acuity visits and deliveries.
Actually, it might be easier if we talk about deliveries first, because that also happens in primary care or
Okay, let's do deliveries. Let's just do high acuity hospital visits. I want to understand, like, for example, is there going to be a way for those visits to be somehow recorded?
yeah. And that, now that we've just made the decision to use open MRS in maternity, in this meeting,
Yes.
there would be. There wasn't before because we had no way to register them. So we just extended the scope of what happens in the hospital. There's going to be a paragraph all over that. But we just extended the scope of what goes on in the hospital. If we register the people, we would have a way to capture them. Register them.
Capture the visit.
Every single person that is going to deliver in the hospital should be known to us. Everybody that goes to the hospital is from the district at primary health. HCL care delivered in districts.
Okay. So is there a specific process for expanding an encounter form? So it would be the same registration process as the
Yeah.
clinic.
And
It would
they
need
should
to be
have their
different account
NID,
form.
if they should be able to pull them in, we could reload them. I mean, there's lots of things that we can do, but this was, and I would love to do that, but I think that adds a huge amount of clinical relevance to what we're doing. So that goes a far way to improving outcomes, opportunities, et cetera. So if we're using open MRS, they're already going to be registered. Almost everybody has had a care previously, and it's a one-off if they haven't. That will be able to read from their barcode.
Same counterform, same everything?
Yeah.
Oh, okay.
The delivery, there's a maternal, so what we had determined in the hospital was that all the they would enter is they use the same maternal summary as everybody else does, the maternal record. And so everybody, you just have the same subset of information from that. The other thing is that we, at that point in time, again, because we had no way to register them, which we do now, so we could modify this. We were all the information we're going to capture from antenatal. In a hospital, they have a tendency to admit people antenatally because they know very well if they send them back home, but they're not likely to come back. They don't send them home, they come back in 3 days because the women get travel distances and they often don't come back. So they're all worried they admit them and keep them. And so the antenatal ward as well as the postpartum, post-section ward, we were only going to capture admit date, discharge diagnosis, and staff. Did they die, or whatever. Maternity, we were going to capture the same maternity information from the register that they would capture if they also had a delivery in the healthcare facility. And for postpartum, we were going to do the same thing, the length of time they were in the hospital and the diagnosis. And that was going to be actually in itself very difficult, but it would be much easier now to register.
So it sounds like the action steps for that are to take the existing forms that you've thought through, sit with the clinicians that work in the maternity ward and see if that is appropriate for them.
Yeah, and that's
Same intervention, essentially.
exactly. And in fact, we created the maternal summary with the clinicians in the hospital.
Okay.
And so that's what we're supposed to be doing next week, this sort of clinical advisory group. We'll show them that as well as the forms and talk that additional work group.
Okay. So in the hospital, it's literally a super clinic
Yeah.
for all practical purposes.
For the hospital, they have an outpatient department as well that sometimes sees patients, which we also visit.
So there would be 2 service areas.
And they're physically separate.
Is the hospital network?
See, this is an issue before. Not 100% sure. I think I'm pretty sure it is. There's another little wrinkle. They're rolling out open clinic.
That's right. Okay. Let's look at it.
So I assume that.
Okay. All right. So that's the hospital is essentially behaving like a clinic. They're going to be reporting a higher acuity of diagnosis, obviously, because they're referred there. Right? They need to also be able to generate referrals back down, I presume, if we put on that pathway of doing referrals.
Right.
Right?
I want that kind of referral.
Yeah.
Send them back to somebody.
Yeah. Okay.
Because they also refer back.
So then all that stuff then is delivered now, right? Okay.
Sorry, just a quick admin announcement. If you're interested in discussing some of the infrastructure and the capacity around that, teams just know we'll be meeting in the restaurant, so they'll get it out.
So the last thing is the delivery event. And mothers can deliver at home. They can deliver at, well, that's the majority of where they deliver now, right? So they deliver most often at the clinic? Oh, good. Unlike Kenya. And so they deliver at home, the clinic, or the district hospital? Okay. And so I guess maybe if we could just talk a little bit around the workflow with that. My presumption is that they don't just get to the clinic or the hospital by themselves. There's some kind of a notification process. Do they get there by themselves?
Yeah, normally, the community health worker can send a rapid SMS at the woman's number, which triggers, it's one of those alert messages that triggers a call to the ambulance. I'm not particularly, so that's the areas that use that. There's 3 ambulances in the entire district. I'm positive that's really excellent use of an ambulance, especially for a no-risk or low-risk pregnancy. So some of them do it and some of them don't. And it just depends on, I guess, personal preference, whatever. The women will often, when they're in labor, they may or may not seek the community health worker. They often do, but then they'll come, says, yeah, your labor supports them, and then they go to the.
So rapid SMS is used as a way of notifying everyone that the person's in labor.
Right, but right now
That happens infrequently. Or
it depends. Some places didn't use it at all, other places said, we should put run me the report to find out how many times that's been used. Because it does automatically generate an ambulance.
Okay. That's pretty powerful.
There's 3 ambulances that's
Yeah.
I don't think that's happening. That's right, so you neighbor or something else, you just SMS when somebody's a neighbor. I'm not joking, that's a good idea. That's okay, I'm not continuing to be positive, that's such a great use of an ambulance.
But that's the standard. That's been set up for a reason, obviously.
Yeah.
Okay. How often does that get triggered, do you know?
So, I don't think everyone can try to send a message for an ambulance.
You gotta protect it.
You must have
I'm just playing. So only the phones that are registered can actually trigger that behavior.
Oh, yeah, sorry, only community
I'm
health.
just playing.
But still.
Darn.
Yeah.
I was going to ask what the incoming SMS number was.
So yes, if the community health worker goes and they send a labor message, then that will trigger a call to the community health worker. I think it's the health center and an ambulance.
And another thing is, it's not the government worker who says, I need an ambulance. Based on information he sent in the SMS, probably the SMS process it and decide which risk may require an ambulance to go and pick the patient to the hospital.
And so the previous encounters, they can put a series of symptoms in on the message, and then that SMS interprets that and decides with acuity, and then whether they go to ambulance or not.
Yeah.
Okay.
That labor is one of those triggers.
Yeah.
Oh, okay.
So it's hemorrhage, so is unconsciousness, so is one other convulsions, I think.
Convulsion, breathing, I think.
Yeah. So it's labor with or without complications.
Okay. Okay. So all deliveries.
Only the community health worker knows, sends the message that she's in labor.
Okay.
And that's why I don't think they use it that much.
Okay. So otherwise, the individual finds their way to a clinic, to a birthing attendant at home, or to a district hospital.
They're not encouraged to be delivering, and that's one of the reasons.
They're not encouraged, but they still do.
Yeah, okay, you still have more than 30% in the homes.
Yeah.
So in where because it's so close to the valley, they said their numbers were much lower than that.
Yeah, I mean, that's the national average.
Yeah. And so in our district, it's much higher.
So can we?
Lower number.
Yeah. Can we walk through all three of those circumstances then? So if they deliver at home, what information about delivery is captured in Vandy?
So,
Or does that happen in the
even if they
18
deliver at home, almost everybody, in excess of 95% of women here, go to the health center within 48 hours.
Okay, so that's the antenatal visit.
No.
Postnatal visit, sorry.
Yeah, so even if they do deliver, they're usually bedding them and they make their way to the hospital within 48
So let's
hours.
keep the postnatal visit separate. Let's do just the delivery event.
Yes.
Okay. So nothing is recorded during the delivery or a home delivered mom. In the clinic, is there anything recorded?
Yeah, well, so wait, that home delivered mom, because they make their way within 24 to 48 hours, it's recorded in the clinic at that time.
At the postnatal visit.
24 hours.
So all people are going to have a postnatal visit.
24 hours, no. Only the people who deliver at home. If you deliver at the facility, you stay a day or so. If you deliver at home, you're brought to the hospital. You still come to the hospital almost within 24 hours, but almost everybody within 48
Okay.
hours of
So
delivery.
there's not a 48-hour antenatal visit for people who deliver in the hospital or in the clinic. Okay.
And so that's why they believe they capture. So they do two things, and there's some slight variability. They either record it in the register, but say the delivery place is home, so they still capture them. And then there's another form that they have to fill out.
Right. So there are complications that in that window, those first couple of days, they can happen once they leave the clinic or the hospital. Those aren't really addressed. When is the first postnatal visit if they deliver in the clinical setting?
So if postnatal visits, they admittedly say they're not very good at, and you actually won't see the form for this. There's a little section on an antenatal form, and when I did sort of the data quality check, often you give me a handful of them, 0 filled out. And they admittedly said, what we typically do is the mom comes in with the baby at 6 weeks. For
6 weeks.
6 weeks. And we use that opportunity to talk to them about what would be postpartum, but there's no physical exam.
Oh, wow.
But they were supposed to.
Wow.
And they said that is something that they could be improved.
Okay. So there's no postnatal visit until 6 weeks
But if they deliver in the facility, they stay.
for 24 hours.
Some longer they have complications.
Okay.
Some
So the
longer
only-
get the babies.
The only immediate postnatal visit is when they deliver at home.
Yeah, and that's really what they consider sort of follow-up to make sure that yeah.
Okay. And so there's one record, there's one standard form that's used, whether they come in 24 to 48 hours later, whether they deliver at the clinic, or they deliver at the hospital. Is that right?
So the standard form is in the maternity register.
Yes.
Yes, and they do that. There is also a form, if they live in a hospital, these are ran, a bunch of people does not charge that. Which they also have in the hospital, they obviously do not have at home. And yes, so they're just recorded in the maternity register. And if they deliver at home, there is an extra piece of paper or an extra form.
Okay. And so is that filled out during the, so I'm just trying to get my hand wrapped around the information that's gathered around the delivery by itself.
That is put into the register shortly after.
And we're gathering that inside
Yes.
the REMRS.
So they no longer actually need to fill out any of the registers. If not, when we do the data mapping, let's see, we have everything from the antenatal register, the maternity register, the antenatal individual form, and the...
So let me just make sure I understand, just reiterate. So if they deliver at home, they come in within 48 hours into the clinic or a hospital, and they fill out the delivery register 48 hours after. If they deliver in the clinic or the hospital, they fill that out as part of getting discharged from the setting. And then the next visit is 6 weeks.
And it's not actually as part of being discharged, they fill it out when they do the delivery.
Yeah, before discharge is what I meant. Yeah. Okay. So there's a standard series of data that are collected following the delivery that describe the delivery.
Yes.
And those are filled out either
Yes.
within 48 hours or while they're in inpatient service. Okay. And if they deliver in the clinic, they don't stay over there, do they?
Yeah. The
So
clinic has beds and everything, so both for their antenatal time, while they're in labor, as well as after they deliver. There's two sides to it, they deliver in the middle. It's usually not, but half of the sites are in Lywood, it's physically separate building from where antenatal care is done. They also have inpatients from acute break that not extended phase.
And is there any special kind of abstract that we need to present to those personnel to support the delivery of that?
Yeah, so it's the workflow that we had talked to them about. It's trickier, they come in day and night all over the place. But in every single special physical location that we went to, they usually had a room, a sleep room maybe attached to where the maternity was, an office with the lock on it. So we talked about having them log in, log in and be able to, with possibly not possible, be able to look at it. The same maternity, exact same type of MRS.
The same exact thing.
Right. And the only difference, so the capturing of the data, the teachers and the health workers all agreed that they would be able to enter the delivery summary information into the computer. I I'm not 100% sure that's going to work out so well, just because more people do deliveries than do antenatal care, and it happens at all hours and stuff like that. So it may not be front of mind. So if it doesn't happen immediately after delivery, it doesn't matter that much. But we should capture and make sure that they have to write it down anyway.
So each of those settings then commits to completing those forms prior to them leaving, essentially.
Yes, and they even complete program and their paper forms. They actually get a PDF reimbursement for completing the program.
Okay. And is that where we stop, or do we do the first child visit as well?
So, two things happen then. One is that we now need to have a way to register the baby that the person searcher was talking about. I want to do that we need a way to generate a form that says this baby's informed, and ultimately go to the parents, who go to civil registration, et cetera, that whole sort of workflow. We need a way to generate, way to generate that report form for the baby.
So, vital registration.
It's not, I think it's a pre-vital registration, it's a notification that it's not, there's another form we have, or the one that's going to print, is that the same form that they will take to that civil registration, they change that into a different form.
Okay, there's a form that exists today, which is the civil registration office. So practically, but if they want to register a child, normally because they want something administrative. So they'll go there and have that form filled. They also write them in the registry books.
The form that we're producing in Open MRS, is it the same as the civil registration form?
It will be, because we are not doing it now, but it will be exactly the same.
Yeah, okay. But that's why I wasn't sure if it was.
So it is a vital registry then?
It is vital registry.
Yes.
And I have the draft that from, actually the draft is got data from what local government needs, what we need, and what rules of justice states need.
And when that happens, do we wish to enter the baby in the client registry?
Correct.
So we need a copy of that form to develop the transaction for capturing the baby, because it's going to be a little different from our existing transaction.
It's new encounter and new...
Yeah, I think it deserves to be its own thing and identified as such.
Correct. I mean, it will be like a patient who comes without identifying people.
Yeah. There may be some extra data elements that aren't regular for the other clients.
The linkage to the mom, for example, you want to keep full of relationships and that sort of thing.
And your personally.
Yeah, I mean, no name actually, because when babies are born, they don't have names. Our culture, they give a name after 8 days.
Right.
So most of the times people have no name whatsoever. So we call it
Their
babies.
family.
Sorry?
Their family name,
No, we don't. It's not like where you take up your there's no family name. You can decide to give your child completely different names and no family name. No, they want to have for sure.
Will we want to get the baby's name when the name is given?
Yeah, actually, I remember the requirements for the country history that we just wrote. There is a standard for that. It's the way you write the baby's name, who has no name. It's baby from
Baby boy one, baby boy two.
One and two if they are twins or triplets. But if it's one, we say baby and the mother's name.
Yeah, because the family name is the mother's name.
Well, it's not a family name because they don't retain that. It says baby D's, for example, and
just a comment, this would probably be a feature of the client registry. I don't think we talked about the linkage between the two.
That is the question, whether it happens at the level of the vital registry or at the level of the shared health record. I think those are both viable options.
But what we decided, Paul, is that we will generate a unique number for the registry, which will still add the person uniquely, until the name is added and everything else.
The question is, where is it important to keep track of the relatedness of people? Sean, are you listening to this? You know, there's an open question about whether relationships between people are at the level of the vital registry or the shared health record. I know the shared health record has the ability to relate them together. I don't know whether MPIs have the ability to relate people together.
Generally speaking, they have that feature that is a relationship.
Okay. So that it could be sorted there then. So there's a convention, I think, that's about to be set here, you know, in terms of when you have relations between people, where do you store those?
Well, the question was, though, does the client registry have that capability? And as people do, that doesn't mean it should, just because it does, doesn't mean it should. Right. So the question, there's advantages to putting in the shared health record versus the client registry. Put it as a clinical observation.
Or both.
My relationship is this person.
Yeah. My heart would tell me to put it in the client registry, but I really could put it in either one.
And. I think it can be and.
Yeah. Well, what's the kind of query that you want to run, though? Is the query to gather clinical data?
Yeah, I mean, the classic example would be maternal child transmission of HIV. If you've got a mom who's HIV positive, clinically, you want to make sure that that can link back to mom's record. So you could imagine like suboptimal prophylaxis prior to delivery could indicate a higher risk of HIV, and you might want to be able to look at the record to see that.
So the point I'm making is if largely the point is to sort of engage in the clinical question, then it probably goes to shared health record.
That's
largely to ask the question, is there a relationship here? Goes in the client record. Do you know the distinction?
I don't know. I see exactly what you're saying. I don't know of a use case for it being the vital registry, but my guess is there probably is. There are some.
Right, and in our client registry spec, we have a number of items having to do with family relationships that are already sort of there, and it doesn't really make clear how that's going to be used, but it does offer the opinion that that's relevant, such as if someone is the head of the household.
So one thing we need to make sure of is the alternate searches to find somebody later on. We've talked about their NID, they don't have that baby. We need to include the fields of parents' names. We do not consider by names because we didn't have a name. And you can search by the mom or dad's name.
No.
Could you please repeat that again? I didn't understand.
So we don't know when you're talking about
Mother's maiden name, mother's first name, mother's last name.
Yeah. So,
That's a query.
yeah, so when there's no hit on an NID, or you don't know the NID, you need to add additional information to make it clear that it's shared health record. So if you just did it on the last name, for example, you get too many hits. We just need to make sure that mother's name and father's name are two of the choices. Because if the baby doesn't have a name and doesn't have an ID, then we need to be able to find them later on.
Depending on the design of the MPI, Sean, my presumption was that linkage could be one way that you would map to maiden name, mother's maiden name, that sort of thing. Like you would literally go to the linked record and look at the maiden name or the mother's name, correct? Or do you just list that as an attribute?
Just like
it's a trait. As a part of the child's record?
It's part of an adult record right now. That's what that's asked when you're admitted. It's your name.
I think what he's saying is replicated in the child's record. That's a trait. So while it's linked, I think what he's saying is that there's a duplication of this data as a separate attribute of the child.
It's not. It's actually a translocation from the mother's last name is her last name in her entry to the registry. The mother's maiden name is the mother's maiden name.
And it imputes that from the other record, or is it just entered twice?
For mother's last name, whatever. All of these things are traits. Even you can create family IDs that is a trait.
Yeah. We can talk about it offline. I think there's just a computing question about how do you arrive at that, but that's for later. I think the point, though, is that maybe the MPI does need to keep track of its linkages just because it's there, we all the information if we got it.
Yeah, I just wanted to try to clarify something with myself. Are we going to at the the OpenRS implementations at clinics, are we going to actually register the child?
That's what's being considered right now, yes. That we would actually use OpenRS to create a vital registration event.
Okay. And that would be something that would trigger the event to correct the child record in the client registry with no ID, just their demographic information, and it'll generate a authorized client ID up on the client registry, and then that was going to have any names, it'll be identified mainly by parents' names.
I think that's right. I think it's what we've been saying, yes.
Okay.
And date of birth. Yes, we know that.
Okay.
Is there in the HILE or very early HILE diagram there was a box for vital registration system? I'm presuming does that thing exist? Is there a database for vital registrations?
No, they're trying to get there.
And then
So right now the shared health record will keep track of those vital events.
Okay.
And my guess is that we might want to pull those messages off to the side in some kind of an archive, so that when the vital registration system comes, they can be loaded with those events. Right.
So then to start processing the child application of the NID, would be then, we talked about something printing the form, is that what you were saying earlier about that would be the same? Or to be using that?
I think what we're saying is prior to them leaving, so if they deliver at home, they come in postpartum. If they deliver there, before they leave, they fill out the form, including this vital registration prior to leaving.
Physical form, not a...
No, it'd be OpenRS form.
OpenRS forms as well. Okay, that forms that we currently have?
That's something new.
Okay.
So my understanding is that the clinician doesn't have to fill it out, right? Can't be populated with the information we know already in the demographics about when it's kicked off from the baby's registration and open MRS. Right?
Wait.
But you have to register the baby.
Wait. The mom comes in, she's going to deliver. The child happens to be alongside the mom. The child is a registered at that event. Mom delivers, now there's baby. So the baby isn't registered in the clinic. The baby was delivered at the clinic. And so now you have to say that this is a new child that's coming into the world. That's what vital registration form is for.
And you wouldn't register them as an open MRS as a patient?
No, because it's the mom that's the patient at the time. Or maybe we're misunderstanding each other.
I'm also...
So what you're saying is that the delivery, the clinician registered both the child and the mom. What happens if the child doesn't make the delivery?
Help me ask
That's what a vital registration event is.
Yeah, so the process I talked about, which we are dealing with Ministry of Health and the local government, are working on the vital registry thing. Now we have designed this form, I'm actually looking at it right now, whereby at birth, a newborn will be registered. And we actually use what is in the country's requirements, which is newborn behind the mother's name. Okay, where the name is known, if the name can be given, some parents might come already with preconceived name. That would be great, so they will be able to give the name and the name written. If not, they'll write the mother's name and say baby so-and-so. Okay? Excuse me, then they'll write the father, the mother, the sex, and the male or female, and also constellation of birth. Whether the birth has taken place at home or in a facility. This is because even those that are born at home, the same form will be filled, but the form will be brought to the healthcare facility. So that's why you have those two options. And the address, which is the district, the state, up to the village. Okay, so let's see. The name, the NID number of the mother will also be recorded on that registration. Yeah, that's pretty much it.
So we know all of that information already, because the mom was registered open MRS, we know that NID for demographics. So just need to add the fact that it's the baby, male, female, date birth.
So you can create a new form.
Oh yeah, okay.
Synthesizes.
So this form will be there, and of course it can be pre-populated by the mother's information, and you just have to add in just a little bit more.
Yeah, that's what I see. And to get back to my earlier question, so you would do what you're calling, I know it's a civil registration, but does that mean that the patient does not, that baby does not get an open MRS number?
No, they do. They do.
That's what I'm asking. So that's a registration, the open MRS, right? They get it.
Yeah, but I'm saying it's all happening during the vital registration event.
Okay.
That's
I
all
was
I'm
saying,
saying. We're not registering anyone when they come in.
there's some separate thing that happens that has nothing to do with open MRS, and that baby's not known with open MRS. Okay, that I understand.
In fact, on this new form, we have also created, we have suggested to have a pre-printed number on that form, and then a small piece of that will be torn off and given to the mother to take with as their mother, their baby's kind of ID. And we hope that that number, which is actually generated by the NID, will be the unique identifier. So when this form goes back to the NID, they'll just enter the information, but the number will be permanent, right? You get what I'm saying?
Yeah, so that's from the range of application numbers, right? That turns into their application.
Yeah, I mean, you may call it the application number, but the thing is, they will get a permanent number right above.
And will that be their
Permanent
NID or
unique
time?
No, it won't be the NID, because the NID is a combination of, it's generated out of your demographic information plus the fingerprints and photos. So there's a few combinations there that they use to generate NID number. So it will be seen at the application number. Whatever the case, it's a unique ID number. Okay.
And so in the clinics that, in the hospitals that we work with,
However, let me
getting
put another question here. This is at the level of ministerial instruction, which is yet to be signed by both ministers. So we don't count it as done, And of course, the logistics that are involved in printing these forms, distributing them, training people, and so on and so forth, will take time. So let's try to find mitigation measures in case this is not yet in place. But this is where we're headed.
I think the key part of what he said that we need to key off of is that the forms that they're going to be manually entering have pre-generated temporary IDs baked into them. Maybe what we do instead for this environment is to just get a list of those IDs, so they don't have to burn all that paper, and then we enter the next off that list and have some kind of process where those are crossed off, and then apply electronically to that record, and then that goes back up to the shared health record. Right? The problem that you're going to have, well, it's not a problem, it's actually a good thing. You're going to be pre-generating stack of these forms in that area, and they're going to be assigned with temporary IDs that are globally defined by the NID group that are unique, and the NID folks are the central authority of those numbers, right? And so what we're suggesting is that we want to make sure that gets into this registration event. We don't want to use that form. We just want to have a list of those numbers, you see? And then
you have space where you can enter that number, I think. Right?
Yes. Yes. So instead of getting a stack of forms that has a sequence, what we're saying is we should get a stack of numbers.
And they'll remember not to print any forms with those numbers.
Print forms with those numbers, what does that mean?
I give you numbers 100 through 200, and then I get Chris to form to those numbers.
Yeah, the NID folks are really good at it, right? And so they'll know that there's such a thing as central authority, and they'll know that each clinic gets a certain allotment. Exactly what we do in the AMPATH, it's a very similar model for temporary IDs. So I think what you're suggesting is NID is going to take on the role of being the central authority for vital registrations. And they're going to create the temporary IDs that you use until the NIDs are created. Okay. So then we just get a list of those temporary IDs to each of those settings, and they're entered as part of the vital registration process with the data that comes from the record, plus some additional new information that's gathered, like birth weight and stuff like that. Right? And then that will trigger a message up to the shared health record. So that will both simultaneously create a new patient registration or a new person registration and an encounter that has the information of the delivery bag with the weight and all that kind of stuff. My guess is that guards weight, some of the basic stuff in the vital registration. Yeah.
Great.
So, one thing I'm not sure of is, so live births that die shortly after, so they were born alive, but they die within an hour or 2 hours or something like that. Do you pay attention to register that? That deaths?
The birth index.
Do you do both events at the same time? Do you register a birth and a death?
Maybe not different.
The current practice, I think, we did one that registration will not have taken place anyway of the birth.
Yeah.